Okay, welcome everyone to our webinar on COVID-19 data resources and research, measures of its impact in the United States. Today, we feature the National Archive of Computerized Data on Aging Director, Dr. James McNally, and the Understanding America Study Director, Dr. Arie Kapteyn. And I'm going to talk a little bit about our plan for today. And we're going to talk a little bit about NACDA and introduce some COVID-19 resources from NACDA and ICPSR, and talk a little bit about using the NACDA Open Aging Repository for code sharing. We're going to show you some resources from the National Institute on Aging, and then we're going to talk a little bit about the Understanding America study, and particularly the COVID-19 survey of the Understanding America study. So now I'm going to hand it over to Dr. James McNally.
Okay, let's see. I'll be right with you. Let me share. Oh, I've already got screen sharing? Yes.
Yep, Jim, you should be able to share your screen, but if not, you can just let me know and I can click through the slides for you.
Oops, is it going?
Yep, we can see it.
Great. And I'm in presentation mode. Fantastic. Well, welcome to the webinar. We appreciate you joining us, and we appreciate you being part of Love Data Week. This is ICPSR's first time to lead this venture, but we've been part of it for a number of years. The focus today is COVID-19, which has devastated our country, devastated the world. In March of last year, NIH asked NACDA and our colleagues at ICPSR to develop a best practice guide for social and behavioral data on COVID. This was really before any new data had been collected. So our goal was to review the best practices for data that might touch on issues of importance to COVID, employment, health, social behaviors, depression, etc., and see what our collections held, and then to provide a summary of the resources that were publicly available. One of the nice things about NACDA and ICPSR in general is we consider ourselves an open source resource for the world. We want people to use our data for research. And we wanted to also suggest other data resources, studies that were being done but not preserved by NACDA or ICPSR. At present, about 2,000 plus copies of this working paper have been distributed and downloaded by researchers. So we're very happy about the response. And if you're interested and haven't gotten it yet, you can download it free of charge anytime you like using the link below. The format we use for this study, because when we wrote it in March originally, there was no good data on COVID. So we're treating it as a pre-test, post-test kind of model. We have data, a number of studies that were done in 2019 or earlier that tell us about how people were behaving prior to the COVID pandemic. And then we have this period of time where first research was deferred because no one could do research. We were locked down. And then slowly groups such as what we'll hear from our colleagues later in the presentation began to collect data on COVID-19. And then the post-test, for example, the 2020 National Health Interview Survey is expected to be released in the fall of this year. So hopefully we'll be able to look at change. How many people lost their jobs? How many people are still unemployed? How many people are depressed? How many people had health events between the 2019 and 2020 period? So this is the pre-test, post-test model. And we also have a growing number of colleagues who are collecting longitudinal data, measuring the process simultaneously across time, which is particularly valuable. And we'll touch on some of those data sets shortly. NACDA and our reporting focused on a number of common elements: quality of life, happiness, crisis management, general health, mental health, healthy aging, anything that touched on the life course. And we looked across data sets to see which studies fulfilled those kinds of variables. Um, this is just a very small cross section of some of the studies we identified. The midlife in the US study, NCHAP from the University of Chicago, American Changing Lives from the University of Michigan, the Health Interview Survey, NHANES, and the Survey of Consumer Attitudes and Behaviors. These are all studies we maintain here at NACDA as part of our collections, but there's many others. And we looked for similar variables across these studies so people could begin to build a picture of how people responded to the COVID pandemic in a non-medical way, in terms of their employment, in terms of their income, in terms of happiness and quality of life. So this is the kind of research we're supporting at the moment, but as more biomedical information becomes available, we'll add that to our collections as well. Getting the data is straightforward. Any one of these studies is available for public download. You would register with NACDA or register with ICPSR to open an account, and then it becomes a simple matter of finding the study through our search engines. You might want the midlife in the United States, the MIDAS-3 study, which is here in the slide. You would search for it, you would get a link and go to it, and then you would see this metadata page that describes the study, and there's a tab for data and documentation. If you click on that, it'll show you what is available, and then you can download the studies. You can download it either as raw data, as a SAS file, SPSS, Stata, R. So it comes in a number of different formats. These are freely available 24 hours a day, every day of the year. So you're always welcome to come and obtain this data and begin to build your research. And one of the nice things about the pre-post model is that you can start developing the models now. You can start using what's available to establish a baseline, a foundation of what health, employment, education, quality of life, depression, all of these measures, what they were like before COVID hit in, the beginning of 2020, and then look for comparative data as it emerges. Again, NHIS is coming out. American Changing Lives has a new survey that's coming out soon. A number of these studies will provide information that allow you to compare change across time. And the longitudinal studies obviously will provide the most detailed information. Now, in terms of COVID-19 resources, there are a number of areas we recommend you go to. ICPSR has established an open source data repository for COVID-19. So if you're collecting data or if you're interested in seeing what other people are collecting on COVID-19, you can go to this website and browse the resources. And if you are collecting COVID-19, even small community or small sample sizes, please share your data. This is how we will learn. This is how we will educate the public. This is how we will add to the research literature. You can also deposit it in the NACDA Open Aging Repository, NACDA OAR, which is an open source data repository specifically for aging related data. Either one of these resources would be fine. Ours focuses on data related to populations, um, to aging population gerontology in the life course. We also highly recommend if you have good data code that uses another data set, but you come up with an innovative way to use this data in a research framework, share your code so others can learn. If you deposit with NACDA OAR or the COVID repository, you get a data object identifier, which is a unique ID for your study. So it becomes searchable in Google and across the internet. So it becomes much easier for people to discover your research and to credit your research. We track downloads, so we keep an eye on which studies are being used, and we'll share that information with investigators who share share their data. And it's fully searchable from ICPSR and NACDA's website. If you search, the open ICPSR studies will have a unique identifier here, but it does show up amongst all of the studies we collect and preserve. NIH has also invested a lot of resources in helping people share and obtain data on COVID-19. NIA and NIH in general consider this to be an important issue. Um, and so they've created a number of resources. This one provides information on how to share, cite, and discover data on COVID-19. If you go here, you'll find a number of recommended repositories for data, including ours. You'll find information on how to put your data set together for deposit, how to find data sets that are being used. Um, the emphasis here is in establishing what we call common data elements, variables and value measures that share similar characteristics. And this is also known as metadata, which is a variety of things: authors, citations, dataset name, publisher, source code, funders, grant numbers, all very important things that should be included in any deposit you make with COVID or any other study. And the goal is to create a catalog of measures that are available on COVID-19. So researchers can more quickly and efficiently identify important studies and get access to data, but also get guidance on the questions they should be asking as they move forward through their own research design. So we highly recommend you visit these sources. Um, Other NIA resources, the Public Health Emergency and Disaster Research Response, DR2. There's also the FANX Toolkit, which provides a number of tools that are quite useful. Uh, the Gateway to Global Aging Data is also a fine resource supported by NIA, which provides access to longitudinal studies of international aging. So these are all resources you should check out if you're interested in data that supports COVID-19 research, aging research in general. Also at ISR, we have a number of longitudinal studies that have included COVID information in their collections in response to the pandemic. Um, the National Health and Aging Trend Study, NHATS, which is based in Johns Hopkins and at ISR here at the University of Michigan, looks at elderly health, disability, and other important issues. In 2020, NHATS did a series of COVID-19 specific add-ons to their main survey. So this information is available now and will continue to be updated for the foreseeable future. The panel study of income dynamics, the PSID, is also added questions on the impacts of COVID-19 to its study. So there will be information such as the impact of stimulus payments on helping people adjust to economic crisis and financial difficulties and general family issues that the PSID has been collecting for decades now. There's also the HRS, which is perhaps the premier aging study in the United States and also the foundation for the HRS sister studies in Europe, in Asia, and they have added a self-administered questionnaire on the COVID-19 impacts. So this will also be available for researchers to use. And as all of these studies are publicly available, so they can be gotten with just registration and download. HRS has also created a COVID-19 research initiatives, which they describe their work with their international partners and the responses they're collecting now, contextual data, state level, a variety of data sets that are both public and included in their more restricted data collections, which are available, just a few more security requirements to go through, but will give you considerably more detail. They offer links to the projects they're developing, the interviews, and the questionnaires. So those can be reviewed at your leisure. It's always a question, why share and reuse data and code? This quote that Catherine Lavender created for us, the standard library saves programmers from having to reinvent the wheel. This is sort of a truism in all our work. Typically, you will find most of the questions you want to ask have already been asked and are available for in a secondary data set. So for baseline research, for preliminary analysis, use our resources. Take advantage of the work that other people have provided as a shared resource for the research community. And if you have written code, particularly for longitudinal data, merging code, manipulation of data, unique analysis approach, share that with others so we can all learn. This is how we will address this crisis, and this is how we will address future crises. We're all a part of the opportunity to make things better for the elderly, for the world as a whole, and we hope that you will join us. If you have any questions or concerns, we are available every day to answer questions. We'll set up Zoom meetings, we will talk to you on the phone, we will communicate through email. If you have any questions about this presentation or any of the information we've talked about, because I know we've gone through it fairly rapidly, please contact us. That is why we are here, to serve you, to facilitate your research, and to make your research more successful. And with that, I will return the presentation to Catherine.
Thank you, Jim. So NACDA has been around for about 35 years, a little bit more than 35 years, and we are funded, as Jim, I think, kind of mentioned earlier on, we're funded by the National Institute on Aging. You can find us at nacda-aging.org, and we've got a little screenshot of our site here. You can find us on Twitter, Facebook, LinkedIn, and if you have questions that you want to send to us after this webinar, you can email us at icpsr-nacda@umich.edu. We're also taking questions after the presentations are done. So you can submit questions through the Zoom functionality. And thank you so much, Jim. And we will share the slides after the presentation. So After addressing those couple details, I'm going to hand it over to the director of the Understanding America study. Arie, you'll need to unmute yourself.
Now I'm. Oh, I see. Okay. So I'm using two screens, so it's a little awkward, but you can see the screen and you can hear it? Okay.
Yes, we can see and hear you.
All right, good. So I think as Catherine indicated, I'm going to talk first a little bit about the Understanding America study, because that's the context in which we're doing our tracking survey, which we call the Understanding Coronavirus in America, which is just, you know, somewhat silly title that relates to the UAS. So let me talk a little bit about what the UAS is. So it's our panel, internet panel that we started in 2014. And what we do, we recruit people by address-based sampling. So we send them letters and then we invite them to be part of our longitudinal study. Currently, we have about 9,000 panel members, and we expect to go up to about 13,000 or so in maybe 2 years from now. So the importance of using address-based sampling is really that, of course, as we all know, not everyone has internet access, and the people who don't have internet access are a specific group. They're more likely to be unemployed, more likely to have lower income, lower education, more likely to be disabled. So what we do is everyone who is interested in joining the panel after we invite them is provided with a tablet and with internet access in case they don't have it. So that's sort of why, certainly that helps the representativeness of the panel. So what we since we have been doing this since 2014, we have extensive information about our panel members, and we have core surveys that are updated every 2 years, pretty much the same pattern that, for example, the HRS uses or the PSID uses. So to give you a sense of the background information we have, obviously we have demographics, we have age, gender, we have race, we have family composition. We have extensive information on economic status, on income, wealth, retirement savings, etc. Information on health, self-reported health, health conditions, health behaviors, personality traits, cognition measures. I think by now we have something like 8 or so different cognitive tests that our respondents have taken. And then every 2 years, we actually administer the complete survey of the health retirement study. And that, is, of course, is responsible for quite a bit of the background information that we have available. So we started tracking the pandemic effects on March 10. And to give you a little bit of context for what I'm going to say later, so on March 10, we fielded the first survey. And during this period, and that survey was in the field until March 31st. And during that period, we decided to start to do tracking, which means that as of April 1, we have a 2-week periodicity in which we pretty much ask the same question every 2 weeks. And then we add some other questions on an ad hoc basis. So the way this works is that every day about 450 respondents answer our questions for a total between 6,000 and 6,500 over 2 weeks. And so everyone is assigned a certain day. So a respondent who is assigned the first Tuesday of the 2-week period, 2 weeks later again will be asked to answer questions the first Tuesday of the 2-week period, etc. And people in principle have 2 weeks to answer the question, but most people actually answer on the assigned day. So by repeating this process every 2 weeks, we can track what's going on, and also we have new data, 450 roughly new responses every night. So one way in which we make data available is that we update, roughly 2,500 graphs that are visible on our website every night. So every night it gets updated. So every next day you see the new data, and these are 1 week average. So you see 1 week averages and see how these change over time. Probably more important for this webinar is that we make all the data available to registered researchers. Currently we have about 250 research groups using the data. So the only requirement for using the data really is that you write a little paragraph what you're going to do with the data. We don't screen on it, but it's just a way of sharing the various IDs that people have. The data are available immediately after the fielding ends. So every other Tuesday midnight, the data come out of the field, and then the next morning you can download the data and use them. And in particular, there is a longitudinal file that pretty much has everything in it that's I find personally very convenient to use, and that's available, roughly Wednesday afternoon or so. And then in addition, the microdata can be linked to contextual data. So there is a fair amount of contextual data on policies, local policies, on infection rates, economic indicators locally that you can link the microdata to. At this point, we expect the tracking surveys to continue until the end of June. By that time, we'll run out of funding, and we'll sort of see what we do at that point. Because at that point, who knows what the situation with COVID is at this point. Things may have changed quite a bit. If needed, we certainly expect to continue in one form. I really don't know yet, what exactly that's going to look like. Here's one of the examples, and I'll show you more of the graphs that we produce every night. So this is a graph that shows whether people had a job in March and then whether they had a job later. And to sort of refer back to the first survey we did, it was a regular survey. It went in the field on March 10. So what happened, most of the responses are the first couple of days during this period, and then later on the response got sort of thin. And that explains why on the left you see the jump. So it looks as if employment went up during March. That's not true. That's just that the laggard in the survey happened to be people who were more likely to have a job. So but what is real though is the enormous fall in employment between March and early April. And if you do the calculation, it's about a loss of about 20% of jobs. Now, you may remember that BLS, the Bureau of Labor Statistics, reported an unemployment rate of about 14.3% or 40.7% for April. But if you look at that documentation, and also if you look at the working paper that was written by Peter Grant later, you can see that actually the true number was probably about 20%. So this number is pretty much on the mark. And also, if you then follow it over time, you see our numbers track the BLS numbers pretty well. And what you see, of course, is that employment sort of recovered a little bit, certainly not to pre-pandemic levels, but it got a little better. So another thing I should note for this audience in particular, that since December 2020, we have an option for people to suggest questions. So, and here's the link actually. So if you go to this link, you can click on it, you can submit questions that you would like to add to the study. We allow for modules that go up to about 1 minute, so roughly 3 or 4 questions. And the way it works is that we first screen the question simply for feasibility and also for overlap. We get proposals every now and then that have questions that already exist in the UAS. So we look at that and we go back and say, well, you really don't need all these questions. You're probably okay with just 1 or 2. Once they're screened, then reviewed by an external committee, because we want to have an independent view on the relevance and importance of the questions that are being suggested. And at this point, we started in December. So far we have fielded 4 of these modules, and we expect to keep fielding new modules every 2 weeks until the end of June. To get you a sense of what's in the tracking surveys, this is a rough summary of what we have, what we have had from the beginning. So we have symptoms, testing, medical care, knowledge of coronavirus, expectations, protective behaviors, risk perceptions, mental health, discrimination and stigma, food security, economic security, housing and debt, social safety net, crime and safety, and of course, labor market outcomes figure prominently in what we do. Then in addition, we have ad hoc additions, if you like. Sometimes we repeat them, sometimes we don't. We have a number of extensive modules on the effect of the pandemic on education, both the effect on children and the effect on parents who have to, teach their children, have to take care of their children when they don't go to school, etc. There's quite a bit on behavioral health. I listed some items there. We have had a number of extensive models on food security and food purchasing behaviors. Use of cash was something we did early on because the Federal Reserve was interested in whether people would start avoiding cash because of fear of contamination. More recently, as you would imagine, we have extensive surveys on vaccination expectation, but also on vaccination hesitancy, how many people got vaccinated, how many people expect to get vaccinated, etc., and attitudes towards public programs. So that sort of summarizes the content we have so far, but obviously, there will be new content added, particularly because of the 1-minute modules that we are allowing. So, just to advertise the potential for analysis, as was clear from what I said earlier, since this panel has been going on for a number of years, we have a lot of background information. So if you download the data, you can of course link the data to the background information we have. The daily tracking helps us to look at the effect of events on any given day, either nationally or locally, because every day, as I said, we have about 450 new observations, so you can see how responses may respond to events in the nation, maybe the election, or maybe announcement of new vaccines, etc. And then, of course, it's very easy to add new questions, and often you can just build on what you already have and just add one question or so to support whatever research you have in mind. So I think what I'll do is I'll spend a little bit of time on give you some examples of what we have done with the data, what people can do with the data. It's really just a small sampling to give a sense of what can be done. So this is something. So first I'll talk about some things we did relatively early on, and then I'll end with something we did recently. So this is an example of actually I have 3 slides on the effect of school closings. So this is an example of who takes care of the children now they don't go to school. And if you look at the top there, we look at employed mothers, employed fathers, you see that the category me, so that's when you say I'm the one mostly responsible for taking care of the children. Then for mothers, it's about 43%. And then for mothers, well, me and my spouse, they will say 30% and going down to others 14%. If you look at the fathers, there are very few who say that they're the primary responsible, that are primarily responsible for taking care of the children. But then about half of them will say, a little less than half will say me and my spouse. So clearly women are bearing the brunt of this. And I guess the good news is that at least they agree. The mothers and fathers agree on who is doing the work. So I think they both agree that the mothers are bearing the brunt. And if you look at unemployed mothers and unemployed fathers, you pretty much see a similar pattern. Now, not surprisingly, since technology now plays a role, right? Teaching is done over Zoom a lot, you see a strong gradient with income. So if you look at the low income, then children are much less likely to have access to internet and laptop and desktop for learning. And if you go up to 150K or higher, then pretty much all children have access. And that's then reflected in this graph, where we see that in the low income households, it's a lot less likely that a child has actually interacted with a teacher through online meetings. Whereas you go up to the higher incomes, you see that number goes up to close to 90%. So all of this, of course, reflects the inequality and opportunities for children in different households to take advantage of what's offered in the current situation. And sort of on the theme of inequality or or effects with or gradients with income or education, this is something that we asked early on. So we asked early on, would you have the kind of job where working from home could be an option if required? And if you look at people with a GED or below, you see it's less than 20%. It's a little more than 15% who could actually do their work from home. And most have to go to work and leave the home. And if you go to college and above, then of course the majority is able to do the work from home. And we've done some work on this, and it has two effects. First of all, if you cannot do the work from home, you're more likely to be exposed to the virus. And of course, we have seen that there is a strong gradient in who gets infected. But also the jobs that require you to leave the home are also the ones that are more likely to disappear. So these are the people who work in restaurants or in tourism industry. So it's a double whammy where if you have a lower education, you're more likely to be exposed to the virus, but you're also more likely to lose your job, and that's what you see in the data quite clearly. A little more about employment effects or unemployment effects. So here we contrast people without college with people who have college, and if you look at the top two lines, this from the first 6 waves of the survey, but it hasn't really changed that much. So if you look at the top 2 lines, you see there's really no difference between women and men. Of course, they're likely to lose some jobs. They go from 74 to 65, so it's about a 9 percentage points job loss, and then it stays pretty stable later on. If you look at the lower incomes, you'll see the fall is more pronounced, and particularly among females. So if you look at females, they go from 51% to 36%. That's a 15 percentage points fall, which is, in other words, is about 1/3 of them lose their job. So really there you see that the inequality is quite pronounced, and in particular it's pronounced for women, where women with lower education, they're really the ones who lost more jobs than anyone else. So another point to make, people have of course talked about the psychological toll of the pandemic quite extensively. And of course you see this in this graph. So this is another graph that we have on the website every day. So you see a peak early on. So around April 1st, thereabouts, all the markers for psychological distress go up quite a bit, but then they fall and they become stable around June or so, mid-June. I think you really don't see much action anymore. Now, of course, one of the things that people have worried about is elderly, right? There's a lot of talk about elderly being lonely and how they might be affected more than anyone else. So let's look at that a little bit. Now, this graph is not the clearest graph in the world, but I'll explain it to you. So this is just the same graph we saw before, but you see two now. One is for people up to about 40, and the other one is people over 65. So the top graph is 65 plus, the bottom graph is for people 39 or below. And so you see similar patterns over time, right? In both cases, it goes up early April and then it falls. But if you look at the numbers, and if you can see it, I'll tell you, if you look at the elderly, so 65 plus, then for example, the blue line of the mild to severe psychological distress is below 20% for the elderly, but it's about 30% for younger people. So it's actually quite a bit high. So it's like 50% higher for younger people than for older people. And that's also true of these other lines that measure anxiety and depression. So the question, of course, is, why is this? Well, probably one of the main reasons why this is the case you see here. So this is a question about where we ask people each time, what's the chance that you will run out of money in the next 3 months? And this is now by age. So if you look at the black line or the bluish line, they're at the top, and typically you get order of magnitude of 20%. If you look at the orange line at the bottom, these are the 65 plus people, and their likelihood of running out of money is much, much lower. And the explanation is fairly obvious. These are much more likely to be retired, less likely to work, so thereby less likely to run the risk of losing a job. So one of the main differences across age groups is simply the financial aspect. And if you worry about your job, if you worry about whether you can pay your rent, then of course that has effects on your mental health. And I think these graphs make this quite clear. And then this is sadly another graph that's according to expectation, because if you break it down by ethnicity, then the whites are the ones who are least likely to worry about running out of money, but then blacks and Hispanics are the ones that are much more likely to get in financial trouble. Okay, then finally, to do something that we just did the other day, even though it's based on data we have been collecting over a long time, this is just a blog we wrote. It's a data brief that we put together. And we talk about mask wearing. And if you ask people whether they're wearing masks, most of them will say, oh yeah, I wear masks. Although there's groups. So for example, if you look at education, then whether your people are high school or less, or whether they have a BA or more, you see there is still a 9 percentage point difference in whether or not they tell us they're wearing masks. And if you look at income, you see higher incomes are more likely to wear a mask. And if you look at age, then people of higher age are also more likely to wear a mask. The question, of course, is when are you wearing a mask? Because wearing a mask when you're by yourself in your home probably is not particularly effective. But what really matters is, are you wearing a mask when you meet other people you're not living with? And so this is an example where we asked people whether they were wearing a mask when they were in close contact with non-household members. And now remarkably, you see that the non-Hispanic whites are actually the least likely to average are, 50, 60%. So that also means that about 50 or 40% of people actually not wearing a mask when they meet people who are not in their household. And you see, and of course, that's also true if you break it down by location, for instance. So the question is, when are people wearing masks and when they're not? Well, I mean, this, I think, shows that people are wearing masks when they have to. If you look at grocery shopping, then 90% of people wearing a mask. But if they go to a bar, or whether they visit other households, then the percent wearing a mask is much less. Now, the number of people going to a bar is pretty low, it's 9%. So you might say it doesn't affect as big population. On the other hand, these are the relatively dangerous, if you like, situation for people when they have the highest risk of being exposed to infection. So anyway, so this is just a sampling of, now my screen sharing has stopped, but it's fine actually, because I just want to say this is just a sampling of what you find if you use the data. And what I want to we want to be relevant, so we want to make the data available as soon as possible. We're doing that. We're always interested in suggestions. It's really important to do things that are important. Of course, every now and then there are things that we forget or we don't realize is important. So we're always very interested in any suggestion of how we can make this more relevant or more interesting.
One thing, if you could touch on, Arie, is getting the data. There are a couple of steps involved. They're simple and they go quickly, but if you could just tell people what they need to do to obtain the data, that would be great.
Yeah, so the slide has a link, right? So, and I think, the slides will be shared. So there's a link, people can click on the link. So they do have to register. And there's sort of two levels in some way. So anyone who wants to use UAS data can register, and essentially you download a page, you say you're going to be responsible as a researcher, and you sign it and you send it back, you get access. For the COVID data, there is an extra step. As I mentioned, we like people to write a paragraph of a couple of sentences, really, in which they indicate what they're going to do with the data. And again, we're not screening on any of that, but by doing that, anyone who's using the data can see what everyone else is doing. So we have, I think, close to 300, little description of what people are doing, just to avoid a little bit of overlap. Or it may be a reason for people to get in touch and say, well, I had the same ID. How about if we join forces? So it's really not onerous, but that's the actual thing that we're asking.
Thank you. Yeah, I registered. It took me about 20 minutes. It was no problem at all, and I found the data to be really nicely formatted and easy to use, and it's a great project. So I'm so appreciative that you were able to join us and talk about this project today. And people should definitely check it out.
Thank you. Catherine, I think you're muted.
I guess I'll jump in while she figures out her audio situation there. So the Q&A is open. If anyone has any questions, we don't have any right now, so I guess I had a couple that just kind of I thought of during the presentation. And the first one's for you, Arie. What kinds of changes did you see, with the survey since it started with the pandemic? Did you see any changes in attitude with, people understanding COVID, or with that kind of stigma that you mentioned for people having tested positive?
Yeah, so I showed one or two graphs about the mental health aspect, right? So mask wearing, and we have graphs of that obviously, and that took a little while, but I think since June or so, it's pretty much up to 90%. So apart from the nuance, as I said, just said that, when people saying they're wearing masks, it's not always clear what it means, but really 90% sort of says they're saying they're wearing masks at least some of the time, and we saw this happening around June. One of the things that hasn't really changed much is questions about the likelihood of being vaccinated. It started at about 65% or so, and that's sort of where it's at right now. We saw some movement around the election, so it seemed as if after the election it suddenly went up, but then it came down again. So I think at the end of the day, it feels more like random variation than anything else. Also, the fact that the vaccines became available, and I think the really positive news about the high efficacy of the vaccines hasn't really moved the needle much. So people are quite entrenched in whether or not they want to be vaccinated, and that I'm surprised by that, I must say. And of course, a lot of the action is in comparing across groups, right? I mean, if you ask, who wants to be vaccinated and who doesn't want to be, then of course you see very, very strong differences. Also by political affiliation, for instance, that's probably not too surprising.
Catherine, is your microphone working, do we think? Ah, yes, okay. Catherine has a question. Arie, you mentioned that the data are available the day after the collection is complete. So what does the UAS team do to the data to prepare it before it's released? For instance, any kind of confidentiality or data cleaning?
No. Yeah. So generally in the UAS, we don't clean anything. The only exception is that we have something. So we have a file with the core information, and we call that a comprehensive file. And it's like the RAND HRS for those who are familiar with that. It has similar, and that we clean. But of course, it also means it's available much later, right? It's like the HRS, just constructing income and wealth variables. It's just a lot of work. But for the rest, we really want data to be available as soon as possible. So in this case, there is no cleaning. So the only thing we do, we just have a process for adding the new wave to the longitudinal file, and we have a crosswalk, an Excel file that gets prepared before release date. All of that is done, pretty much automatically on Wednesday morning. So we really don't do any cleaning. So people will see what it is, and any mistake in there, you will see as a data user.
And then what format are these data in, or is it like Stata SPSS?
It's data, but we can, so just to make it easy, it's data, but then people can get, if they want to, they can get it in any other format if they like. You will have it, but you cannot download an SPSS, but you can ask us, can I get an SPSS version, and you get that.
Okay.
I just wanted to mention that on January 26th, the National Institutes of Aging released a notice of special interest on aging relevant behavioral and social science research on coronavirus disease. There's a focus on longitudinal data analysis, but I put the link up in the comments, and I think if you're interested in pursuing research, this is a mechanism you should look at. And
Yeah.
if we can help you identify data resources that would help you apply for this, definitely get in touch with us. This just came out, a week or so ago, so
Right.
it's hot off the press. And I would also mention that now, exciting is not the right word to use when we're talking about something as horrible as COVID. But right now, we're starting to see the results pour out. And there's a lot of information out there. And I really encourage everyone to start looking around. contact us, contact Arie. The HRS has help services. NHATS has help services. There's a lot of really good, solid data that's been collected for years now. And this introduction of COVID into people's lives has been measured, at least over the past year. And we're very curious to see how people will adapt. It reminds me in some ways to the Katrina catastrophe in Louisiana, where there was a number of very useful data sets that emerged after the disaster to allow people to study the post effects of this kind of crisis. So we really appreciate you being here. We appreciate you investing your time to learn a little bit about what we're doing. We should be updating the working paper in the near future with new information. And any questions, concerns, or issues that we can help you address, contact us. This is what we do. This is why NIA funds us. We want to support your research. We want to promote your research, and we want to help everyone in the aging community better serve the gerontological world. So I think we've lost Catherine's voice, which is too bad.
Can you hear me?
Yes, yes, we can.
Yay. Okay. Yes, thank you. And I wanted to put in one last point, unless anybody else has any other questions, but the point is that both NACDA, ICPSR, and the UAS site share data-related publications, and we encourage data users to check out the data-related publications so that you can see what others in the research community are doing with the various data that we house. And it can be helpful when you're thinking about your research questions. Okay, thank you so much to everyone for attending, and thank you to Scott for helping us set up this webinar, and to Jim and Arie for their wonderful presentations. And we look forward to hearing from you all about any questions you might have in the future. And we will definitely share the materials after this with the attendees, and we'll put the slides up on the NACDA site once they are cleaned up with ADA compliance.
All right.
Okay. Well, does anyone else have anything to add, or I think we can be done? All right. Thank you, everyone.
All right, thanks.